Good afternoon, everyone. Thank you for joining us for another FCI seminar series. This week, I'm very excited to introduce our nurse practitioner and clinician for our FCI mobile clinic and wellness clinic, Dr. Aimee Green. She will be talking today about hormone replacement therapy in our Florida firefighters. Dr. Green has been with us for the last 2 years, again, leading our clinical group, our wellness clinic, working very closely with Johanna Garibaldi, our nurse navigator. Without further ado, I'd like to give the floor to Dr. Aimee Green.
Thank you, Dr. Soli. Thank you for the introduction, and I'm looking forward to sharing some of our FCI research with everyone today regarding hormone replacement therapy and cancer status among Florida firefighters. And this is some work from our Firefighter Cancer Initiative. So to start things off, I'm going to give a pretty good overview of hormone replacement therapy, just to provide background for the context of our study. So hormone replacement therapy is defined as the administration of exogenous hormones to replace or restore suboptimal levels. So our body has various hormones, and we can replace those various hormones with therapies that we have. But for the context of today's study and conversation, we're going to be specifically talking about sex hormones in the context of menopausal hormone therapy and androgen therapy. So before we get into all the details of both of those therapies, these are some of the common routes of administration, and we can use these for both our menopausal hormone therapy or androgen therapy. They can be given in oral form through pills or other formulations, topical in cream or patches, and injections such as an intramuscular injection, and pellet therapy, which is basically a procedure that is done to place a pill or pellet under the skin in the subcutaneous fat. So ladies first, first I'm going to begin with our menopausal hormone therapy by discussing a little bit about the menopausal transition and why sometimes we use menopausal hormone therapy in our female population. You know, our female firefighter population is smaller compared to the male, but still very, very important population for us to address. So the menopausal transition. The menopausal transition occurs over the course of about 1 to 3 years. And basically, this is a time period where the ovaries are working somewhat, but not producing consistently the hormones that normally get produced by the ovaries when they're functioning normally. So we call this period the perimenopause period. And this usually occurs between the ages of 40s to 50s, depending on the age of full menopausal transition. So we call a woman officially postmenopausal after their last period was approximately 12 months. So basically amenorrhea for 12 months, and that they could or could not have menopausal symptoms. And usually what we'll see in the FSH, or the follicle stimulating hormone, the signal that the brain sends to the ovaries, we'll see that very high, because basically the brain is trying to still stimulate the ovaries, even though the ovaries aren't going to respond. And then we see the hormone levels, estradiol, progesterone, testosterone in the female, very low, because the ovaries are not producing those hormones anymore. So women can have symptoms of menopause throughout this transition period, and then also most often in the initial postmenopausal period, and symptoms tend to improve or dissipate over time. So what are some of the most common symptoms that we see with menopause? So first one that we think of off the top of our head a lot of times are the vasomotor symptoms, right? The hot flashes, night sweats, waking up from those hormone fluctuations. Another one is insomnia or trouble sleeping. So whether it's related to the hot flashes or not, night sweats or not, but just trouble getting to sleep, trouble staying asleep. And then our vaginal symptoms, which oftentimes are related to vaginal dryness, pain with intercourse, and then genitourinary symptoms that have to do with things like incontinence and whatnot. Also, the last one is mood. So we see changes in mood from the fluctuations in the hormones. This could look like depressive symptoms, anxiety, or just overall changes in mood. In addition to these 4 core symptoms, some of the things that sometimes get reported by women is joint aches, changes in cognition, um, and basically also some brain fog and things like that. We also see over this course that there's an increase in your cardiovascular risk. So post-menopause, cardiovascular risk goes up, as does bone loss. So bone loss begins in this period as well. So there's some health implications. We also see some changes in body composition, such as a decrease in lean muscle mass, increase in overall fat tissue, and skin changes. So skin changes such as those related to collagen, so skin wrinkling, dryness. These are just some of the few magical symptoms of menopause that we see that patients seek treatment for. So when patients seek treatment, and what's been studied in the literature is basically under the umbrella of menopausal hormone therapy, there's 2 main umbrellas. So we have our estrogen only arm, which is basically designated for women who don't have a uterus. So if they've had a total hysterectomy, they don't have a uterus, the estrogen only therapy is isolated for those women. And then we have our other arm, which is our estrogen and progesterone therapy, so combination therapy. And the progesterone is given to basically mitigate the effects of the estrogen on the uterine lining. So if we give unopposed estrogen to a woman who still has her uterus, we will build a lining inside the uterus and she will begin to menstruate, which most of the time is not wanted after menopause. It's the one benefit. So the progesterone or progestins, which are synthetic progesterones, are given to mitigate that and basically keep balance with the estrogen progesterone and thin that lining so that they don't get a menstrual period after they're in menopause. So menopause hormone therapy, what are the risks and benefits? So the biggest trial to date that we always refer to when we talk about menopausal hormone therapy is the Women's Health Initiative. So this study was done in the early 2000s, late 1990s, and basically had a large population, about, I believe it's like 67,000, like a large population of women that were being studied in the 2 arms. So there was an estrogen only arm and an estrogen progestin arm of the study. And they were looking at the effects of hormone therapy on these women. However, the average age of participants was about 67 years of age, which is traditionally a little bit older than when menopause occurs, right? Because we know the average age of menopause is approximately 51 years of age. So in 2002, they had to stop the estrogen progestin arm of the study due to complications related to cardiovascular risk and breast cancer risk. So they saw an increase in both of those in that arm of the study, and therefore halted the study. And then when the data was analyzed, again, the criticism was the age of the women and the fact that most women don't seek care after 60. So basically what they went ahead and did, and the graph that it's showing here, is they went back and looked at the women that were ages 50 to 59 to see what the potential risks and benefits were in that specific population, which is the population that usually seeks care. So when we look at the top, I know we're here to discuss cancer, but can't discuss cancer without coronary artery disease, right? Because the heart disease is still our #1 killer. So heart disease. So if you look at the graph, just to clarify, the blue line is going to show the estrogen only arm. And then the peach line is going to show the estrogen and progesterone arm, or progestin, because it was synthetics that were given. And then to the left are anything that was showed an increased risk in that population. And then to the right are any of the potential benefits in the population. So if we look at the top in our estrogen only arm of the study, we saw potential benefit when it came to cardiovascular risk. But in our estrogen progesterone arm, we did see that increased risk. Same thing with invasive breast cancer. So in the estrogen-only arm, we saw potential benefits, whereas in the estrogen progestin arm, we saw potential risk. And that is the same for our stroke. For pulmonary embolism or PE, we saw an increased risk for both arms of the study, as with DVT. However, with colorectal cancer, we saw a potential protective benefit with prevention of colorectal cancer in both arms of the study. And then endometrial was no different. And then with lung cancer, we saw a potential benefit in the estrogen progesterone arm of the study. With fractures, for all fractures, so bone health, we saw a protective effect in both arms of the study, as we did with all-cause mortality and diabetes, blood sugar control. So that was all of my background for menopausal hormone therapy. I know that our firefighter population is largely male, so this is the overarching question we get is testosterone and androgen therapy. What is a normal testosterone level? So we're going to address that. And we're also going to address a little bit about what symptoms are associated with androgen therapy and how to mitigate some of those. So this study was basically done in order to come up with testosterone level norms. So this was a study that was done using data from 4 other studies. So a European study and also the Framingham Heart Study and a couple other trials that were included. And it looked at men in these various large studies across different age groups and across different weight or BMI categories and tried to quantify what is the norm. So what is an average testosterone level across the age groups? So if you look at the left, those were the descriptive statistics of the sample used. And then if you look at the right, that's the average categories circled in orange for each age group. So if you look at the top, we have the age groups. And then on the side, there's the percentile. So I circled the 50th percentile. So this is kind of our average, right? So if you're 50th percentile, that's considered the norm or the average, and that's where we get kind of our lab values from. So average across the age groups was anywhere between our mid 400s to 500s. And then I do want to highlight at the top end, right? So in our 95th or 97th percentile there at the bottom, it was about the 8 to 900s. So we had a normal range, if you were average, of somewhere between in the 400s to somewhere in between the 8 or 900s. This is important because when we talk about testosterone therapy, we talk about when to treat, right? In the next slide, I'm going to address the signs and symptoms of androgen deficiency. But if, a lot of those signs and symptoms are non-specific, so we want to make sure we're treating the right thing and that we're not necessarily treating a testosterone level when we need to be treating maybe a thyroid problem or something else that could be causing those same symptoms. So very important that we keep these norm values in mind in light of treatment. Also, I will say that while we're monitoring someone that's taking androgen therapy, we want to keep these values in mind as a goal, right? So we don't need to shoot for the stars. A lot of times with androgen therapy, less is more. And we don't need these super physiologic doses that get testosterone levels to the 3,000, 4,000 level because those are indeed super physiologic and not necessary. And in all the studies that we look at, we can stick to basically these range, whether we're looking at normal endogenous levels or if we're going to be replacing with exogenous testosterone, keeping these levels in mind. So androgen deficiency symptoms, again, so our sexual symptoms are sometimes the ones highlighted. So changes in libido, things like erectile dysfunction can or can't be associated with androgen deficiency. And then we have our non-sexual symptoms, which include things like changes in energy level, mood, cognition, all of these things, right? So the quote unquote not feeling like yourself, not feeling as youthful as you did before. But again, these are non-specific. So fatigue and decreased energy is very non-specific. And in our firefighter population, we want to keep in mind things like sleep deprivation and shift work that can also cause these same symptoms. And then of particular concern are the signs and symptoms or adverse effects of true androgen deficiency. So testosterone helps with a lot of things, but mostly when we study it, we look at it for its cardioprotective effects, probably because of its implications on things like blood sugar control. So with androgen deficiency, we see things like obesity, insulin resistance, and then also changes in muscle mass and bone mineral density decrease in both. So these are some of the key signs that we look for that we want to potentially address when we suggest or give androgen therapies. So under the arm of androgen therapy, there's not just TRT. So we actually have testosterone replacement, which would be our TRT. And then there's testosterone restoration, right, which are using different kind of medications and therapies to try to restore the body's own natural function and produce androgens endogenously instead of providing exogenous testosterone. So exogenous testosterone, so this is basically a very pretty picture to just show the mechanism of action of the different therapies available. So exogenous testosterone is our TRT. Okay, so our TRT is given exogenously, means outside of the body, and basically it overrides anything that the body would produce on its own, right? So when we give an exogenous hormone, that signals the brain to kind of put a pause on its own production because we're getting it from the outside, right? So it works at the level of the brain and stopping those signals from being sent that we need to produce testosterone because we're already getting it from another source. In contrast, estrogen restoration works in various ways. So our most common therapy that's used for estrogen restoration, I would say, is our selective estrogen receptor modulators, or our SERMs. And the one that's been studied in particular is clomiphene. So clomiphene works by basically saturating the estrogen receptors at the level, again, of the brain, so that basically it shuts down the natural negative feedback. So these receptors are what would trigger the body to normally stop producing its own testosterone, but we saturate those receptors with this therapy, and basically then the body continues to produce testosterone, and we can raise levels that way. The next form is HCG, and this basically works by mimicking LH and signaling testosterone production that way. And then our least frequently used, I would say, is our aromatase inhibitors. So aromatization is a big way of saying the conversion of testosterone to estrogen. This happens naturally in our bodies. And the higher level of testosterone, the more aromatization normally that we have. So these aromatase inhibitors, they work by basically inhibiting that translation of the testosterone into estrogen, therefore trying to preserve whatever testosterone the body is producing. So potential risks and benefits. So we talked about some of the benefits related to cardiovascular and metabolic health, bone health, and muscle strength. But like if anything else, right, there's potential risks that we have to keep in mind and mitigate if a patient is on therapy. So this basically chart summarizes that. So cardiovascular risk, right? We want to mitigate that by making sure we're checking the patient's blood pressure and lipids periodically. For erythrocytosis or increase in our hematocrit, we want to make sure we're checking that CBC and treating accordingly, or stopping treatment if indicated, as with fluid retention. I'll skip over the prostate for now because I'm going to address that also in the subsequent slide. And things like acne, right? We want to make sure we're mitigating those by either changing the dose or if a patient so chooses that the symptoms, the outweigh the benefits, then stopping the treatment. Of more particular concern, things like hepatotoxicity. So testosterone does get metabolized in the liver. So we want to make sure that we're monitoring our liver function tests and treating appropriately or stopping treatment if those LFTs increase. Fertility, when we give exogenous testosterone, because of what it does to the signaling in the brain, we actually decrease sperm count, so it can cause a side effect of infertility. So we want to keep that in mind for our population that is still trying to conceive, to address that. And now we don't see that same effect when we use testosterone restoration therapies, but definitely with our exogenous testosterone. Obstructive sleep apnea has also been associated as a potential complication. So we want to make sure we're monitoring for that periodically. And then gynecomastia is another big one, right? Because of what I said, right? The aromatization that occurs. So naturally, your body converts some of its testosterone into estrogen. If you're getting large doses of testosterone, that's going to increase how much is being converted into estrogen. So particularly with big doses of TRT, we see they're predisposed to getting gynecomastia or growing breast tissue. So this sometimes gets mitigated by giving an aromatase inhibitor with in conjunction with the TRT. And then to go back to our prostate, in the next slide, I'm going to address this in more detail, but definitely what we've seen with both BPH and prostate cancer is that on patients that are on TRT, we want to be monitoring that PSA periodically, particularly looking for any kind of increase or any kind of new symptoms that would indicate prostate growth, and definitely refer them to urology as needed. So testosterone in the prostate. So androgen deprivation therapy is basically has been the mainstay of prostate cancer treatment. So it was always thought that testosterone had a direct effect on the prostate, and that it always caused growth of the prostate tissue and potentially that increased cancer risk. And also, if there were any cancer cells, basically put fuel to the fire. However, in 2009, that model kind of got shifted, and basically a review of the literature at that time suggested this new model called the saturation model. So the saturation model basically was proposed after reviewing the literature of several studies and looking at testosterone and its effects on the prostate. And what they found was basically that men who had a testosterone level, a total testosterone level of approximately 250, those men that had less than 250, we did see an increase, right? So if I gave testosterone replacement therapy to a man who had a testosterone level less than 250, I saw that increase in growth in the prostate, and I saw an increase in the PSA. However, if a man had a testosterone level that was approximately 250 or greater, we didn't see that same increase. So then this model was proposed that basically the prostate was saturated at a level of testosterone level of approximately around 250, and that there was no effect beyond that. This model is still controversial. So we're in 2021. It's still the model being used, but it's still controversial as to depending on which clinician that you speak to. So I know that was a lot of background about HRT, but I think it was really important to kind of set the stage for our particular study and how all of this translates over to our firefighter population. So to give a little bit of background, particularly about our study. So all of the studies that I reviewed with you were done on our general population, right? We don't know how many people in, let's say, the Women's Health Initiative were firefighters, right? We don't know how many female firefighters they had. As the same for some of our male studies. So little is really known in our firefighter population regarding HRT use, what normal hormone levels look like. So what we wanted to do was basically characterize HRT use and cancer status in our cohort of Florida firefighters to kind of just explore the topic. When you do a literature search related to firefighters and HRT, there's like less than a handful of studies. And when you do it related to cancer, there's actually no research being done. Yet we know with the commercialization of particularly androgen therapy, it's being used in our population at large, including our firefighters. So in order to do this, we went ahead and looked at our baseline survey data from 2015 to 2021. And we looked at our annual cancer survey data. And we looked at a couple things. We looked at the report of ever using HRT, and we looked at the report of ever having a cancer diagnosis. So the questions regarding HRT included what have you ever taken hormone replacement therapy, and what type, if they had said yes, what type did they take for the longest period of time? And the same with cancer status. Had they ever had a cancer diagnosis, and if so, which type of cancer? We also looked at things like occupational history, sociodemographics, and health behavior practices in our sample. So what did we find? So the main findings, just to summarize, was in our sample, Florida firefighters, we did find an association between reports of ever using HRT and ever being diagnosed with cancer. In fact, firefighters that reported using HRT were 1.92 times more likely to report ever having a cancer diagnosis. However, the most common category of cancer reported was skin cancers and prostate cancers. And there's a slide that goes into a little bit more detail on that coming up. Most participants were male, not surprising in our firefighter population, and they also reported not knowing the type of HRT that they were on. So here is a table that reviews the descriptive statistics of our sample. So we had a sample of just under 2,500 firefighters. Of those 2,500, approximately 500 reported ever using HRT, and approximately a little less than 200 ever reported having a cancer diagnosis. So, and then of those who reported having a cancer diagnosis, the most frequently reported characteristics were male gender, white race, non-Hispanic for ethnicity, marital status married, and years as a firefighter greater than 6 years as a firefighter. So that was for our population that reported having a cancer diagnosis. This table reviews the results of the univariable and multivariable logistic regressions related to our two questions, right? Our HRT use ever and our cancer diagnosis ever. And this is the one that shows that increase association, right? That 1.92 times more likely to report cancer diagnosis in our HRT users. So this is the breakdown of the actual cancers reported. So if they reported a cancer diagnosis, which ones were reported, and you can see most of them were non-melanoma skin, followed by melanoma and skin, other types or didn't know what type. And then after that, prostate and thyroid. So we didn't see, a large number of any largely female cancers, such as like our breast cancer, things like that, that have been linked to HRT use. However, our population of women, as with most of our firefighter studies, was small, significantly smaller than our male population. So here's a breakdown of HRT use, the population of HRT use by gender. So 90% of our HRT users were male, and like I said, just about under 10% were female. And then when you look to the left, there's an overview of what type of HRT was reported as being used. Most people in our sample, most firefighters reported not knowing what type of HRT they were on. This could be due to the largely more female type of hormones on the options, which were mostly geared towards estrogen and progesterone therapies, and not androgen therapies in our largely male sample. So conclusions: in the general population, HRT has been suggested for use to address the symptoms of both menopause and/or androgen deficiency after a detailed risk-benefit analysis is performed and with close monitoring between the clinician and the patient. In our sample of firefighters, Florida firefighters, there was an association between ever using HRT and ever being diagnosed with cancer. And the most frequently reported cancers were skin cancers, followed by prostate. Definitely more research is needed, specifically in our firefighter population, to further explore what a normal testosterone or estrogen level or FSH or any of these look like in our firefighter population, how this may be influenced by their shift work, what symptoms are influenced by their shift work, and then also what their HRT use looks like, right? What kind are they using? What the perception of HRT use and safety risk benefits are, and how that plays into part with any kind of cancer risk. So that concludes my presentation. I'd like to acknowledge all the work that went into this, all the co-investigators and co-authors, and Dr. Caban Martinez for helping with our statistical analysis, and all the entities at University of Miami, our Sylvester Comprehensive Cancer Center, Departments of Family Medicine, Public Health Sciences and Medicine, and then of course our state of Florida grant appropriation, which allows us to do this work, as well as our principal investigator, Dr. Aaron Kobitz, and our many firefighter partners that help contribute to all this important research that's being done. These are my references, and I will open it up for questions. If you have any questions, I believe you're supposed to put it in the Q&A chat, and then I guess Dr. Soli can let me know if there's any questions.
Thanks, Aimee. That was awesome. Thanks for sharing. So I do see a couple questions. So we have, they want to know if the slides will be available. So yes, so our slides and the recording of the presentation will be uploaded online to our website. So if you go to sylvester.org/firefighters, you're able to see all of the past seminars. And this one will be added to that. Anyone else on the line that has any questions for Dr. Green? Some more coming through. Oh, yes, we can put the site in the chat. All right, so I don't think we have any other questions. Or Aimee, do you want to discuss any experience you've had with firefighters? I know you see a lot of them in the clinic. You talk with them, maybe some frequently asked questions that come up when you're out in the field.
Yeah, sure. Basically, I think a lot of the things that come up in clinic or in the field are more of the safety parameter questions regarding HRT use. So again, we know that androgen therapy is our big one with our largely male population. And they want to know how safe it is to use, or some of them, I guess, just want to make sure that they're doing the right thing. My caution always to my firefighter patients is to make sure that it's being done in an evidence-based manner. So it's really important that wherever they're seeking care, they're going to someone that's well-versed in the literature regarding androgen therapy and the different options. Unfortunately, a lot of our therapy regarding this type of treatment has been very commercialized, and I would never want them to fall into the wrong hands of someone that was just trying to sell them a product or a vision instead of actually improve their health, specifically with our firefighter population that we know is already at risk for cancer. So definitely that would be my precaution, or something that comes up often. The other thing that sometimes comes up is the difference with testosterone levels. You know, we have total and we have free testosterone. And most of the studies are actually done on total testosterone. So that's what we see. But generally, when we talk about free testosterone levels, that level, the average is usually where we have our threshold for treatment is around 220. So in case that question was out there, wanted to address that. If there's any other questions, comments, concerns, I'd be happy to address some. If not, like Dr. Sully said, the presentation will be available for review on our website.
Thanks, Amy. So we did get a couple other questions. So another question that came through from Dr. Donner was, is there any data on women firefighters and hormone replacement therapy after years of service and cancer?
So if there's anything on female, no, there's nothing on female firefighters specifically. When you look at the data on firefighters and HRT, there's some done in light to cardiovascular health. So there's a study about ventricular wall thickness and how a higher testosterone level basically causes less of that thickness. So more of like showing that cardioprotective effect. And then there's some related to stress and cortisol levels and things like that. But nothing in our female firefighter population. I know it's a small population, but again, so important to address this, right? Because the concern, me as a clinician and research team partner, is again our firefighter population is particularly vulnerable to different forms of cancer. So when they go seek care for these symptoms, we want to make sure that they're seeking care in the right places and not kind of being grouped into the general population and be given recommendations or not monitoring things as closely as should be if they're receiving these therapies. But no, there's nothing done. This is definitely an avenue where there's a lot of room for growth.
Yeah, and just to add, another question came in very similar to the same thing, asking about female reproductive cancers associated with HRT, and is there any efforts that are being done? So as Aimee has said, there really isn't anything out there, but we are here at Sylvester, we are working on a new study with our women firefighters that we are, writing the protocol right now of creating a women's cohort. And really focusing on thyroid, but also reproductive cancers in our female firefighters. Right now, we currently have a cervical cancer screening program. We're also looking at microbiome and also exposure to PAHs. So that is something that's currently going on that we're actively enrolling, but we're also creating another cohort where we can look at some of these risks specific to our female firefighters.
Yeah, and in the general population, females, the main things that have been studied are any of our estrogen dependent cancers is the concern that when we give these women HRT, we could increase their risk for things like breast cancer, uterine cancer, endometrial lining, by stimulating that production. But basically in the firefighter population, there hasn't been anything done. And like I said, in the general population, we do see that those risks tend to be age dependent, meaning the threshold in our women tends to be that 60-year-olds cutoff, whereas women, receiving hormone therapy greater than 60 would have an increased risk compared to women receiving the therapies between the ages of 50 to 59. And that's from the data from the Women's Health Initiative. All my references will be also included when we post the presentation. So if there's any articles that look of interest to you, feel free to look them up.
Okay. We had another comment, that'd be interesting to see if the female firefighters who use contraceptive devices, IUDs with progesterone are more protected. So a really good point.
Yeah, we don't know yet. Definitely nothing regarding hormone therapy for contraception purposes. That we won't know until years later. But yes, it's another important avenue, right? Because we not only in our menopausal women taking hormone therapy, technically contraception is a form of hormone therapy. So we do give smaller doses of estrogen and progestins. So is that protective or is it not protective, right? In our women's health initiative, we only looked at older women menopausal. So we would need to see what that looked like in our premenopausal, normal women of reproductive age. What that looked like administering those similar hormones, totally different doses, totally different use. But what that looked like long term. We also are using things like IUDs and implanted contraceptive devices, which actually go in the subcutaneous tissue as well. So how does that differ from taking an oral contraceptive? There's a lot of room in hormone therapy for research and nothing really in our firefighter population. We're just going based off of what's been done in the general population.
Yep. And Matt Alba, who's on the call, is on the board of directors for the San Francisco Firefighter Cancer Prevention Foundation. So he shared a link with us that I've put in the chat for anyone to take a look at. He says it includes some peer-reviewed studies that are on their website. So just as an additional resource for others to share. So these seminar series, we are working on getting them CEUs for paramedics and for any other healthcare workers that are coming. So we are in the works of doing that for those who are asking. And once we have that all set up, we will let you know. But currently they're not there yet. All right. I don't see any further questions. So again, thank you so much, Aimee, Dr. Green, for presenting. I think this was a really fabulous talk. We had some great questions, and thank you everyone for joining. So we will see you next month. Again, we meet every month. This is what, the third Wednesday of the month, or the fourth Wednesday. The third Wednesday, we have our monthly Firefighter Cancer Initiative meeting that all are welcome to join to hear all the project updates from each of our cores. And then we follow that up with our seminar series. Next month, we will be moving our seminar series to the third week. I believe we're going to do it on the Tuesday before Thanksgiving. So that will change a little bit of the schedule for November and December because of the holidays. But after that, we'll go back to our third and fourth Wednesdays of the month for our FCI and our seminar series. Thank you guys all for joining us again. And if you have any questions, please feel free to reach out to any of us. Take care.